Hello, medical students of the University of Jaffna. My name is Dr. Rajasekaran Sandrasegaram. I'm a graduate from the Jaffna Medical Faculty, University of Jaffna. Currently working in the UK as a final year senior registrar in psychiatry. I have been given this opportunity to compile a presentation on alcohol misuse for the online module of the medical faculty. I have done my level best and I hope you will find this interesting and useful. I like to start off with a bit of history about alcohol use. The alcohol was used in Indus Valley civilization uh, approximately 5,000 years ago, and it was made by fermenting rice, wheat, fruits, and similar substances. It's interesting to note that its harmful effects also been known for thousands of years, as described in ancient Ayurvedic texts. Um, Alcohol, when used in moderation, it's like a medicine, but in excess, it's like a poison. Many heads of religions and religious leaders advised against alcohol and, in fact, preached for complete abstinence. The Lord Buddha advised all his disciples to refrain from drinking alcohol, and in fact, it's the one of the basic precept of Buddhism. Similarly, in Hinduism, the great Adi Shankaracharya advised for complete abstinence, and Mahavira, the founder of Jainism, also did the same. In recent times, the Mahatma Gandhi advised for abstinence from alcohol, and his impact is still can be seen in Gujarat, where he was born in India. That there was ban on alcohol production and selling. In Western world, the European countries also, that there were documentation of alcohol use as early as 3000 BC. But it is worth noticing that the harmful effects of alcohol also seems to have been noticed by the ancient rulers. The Roman Emperor Domitian attempted to restrict wine production and its distribution, approximately 2000 years ago. And there were uh, various documented evidence about the moral disapproval of drinking and drunkenness in communities, seen in various documentation in Western world as well. Although consumption of wine play a role in Christian worship, the drunkenness was frowned upon by the Christian churches. Similarly, Prophet Muhammad also asked his followers to completely remain abstinent from alcohol. So these details I gather from Oxford Handbook of Psychiatry, 3rd edition. Epidemiology. Approximately 28% of men and 10% of women in Sri Lanka drink alcohol, according to WHO data 2010. In another study conducted by the Alcohol and Drug Information Center Sri Lanka, they have found 43% of urban dwellers in Sri Lanka and 65% of male estate workers and 25% of female estate workers. So estate workers are the people who work in tea plantation. 50% of fathers of school children consume alcohol. In another study by Dr. Abesinger, it's been found that among the new entrants to the universities, nearly 18% of students drink alcohol. If we look into the prevalence of alcohol misuse disorder in a period of 1 year in 2010, 5.6% of men in Sri Lanka have alcohol use disorder. These include alcohol dependence and harmful use of alcohol, whereas 0.6% of women have the same problem, and when you combine both sexes, it's 3%. But interestingly, if you look at the Southeast Asian region, it is 2.2%. So clearly, Sri Lanka has more prevalence of alcohol misuse problem than the other countries in the same region. Further data about heavy drinking across the world, it's been noticed that heavy drinking is more common in men, particularly in lower socio-economic groups, and certain professions such as the alcohol industry workers, traveling salesmen, and doctors are more at risk. The onset of alcohol use seems to be late teens to early 20s for men, but the cause is often insidious, and the recognition of alcohol dependence and misuse problems, significant misuse problem, seems to occur around the age of 30. The onset is later in women, and they are more likely to drink alone, delay in seeking treatment due to stigma and various other issues, and have higher rates of comorbid mental illness as well. More on epidemiology. Women have a stronger genetic predisposition to alcoholism, and more physical complications seems to occur in women. This is partly because of their fat distribution, as they have more percentage of fat and less percentage of water compared to men. The blood alcohol levels tend to rise rapidly, and that's one of the explanation for this. The divorced and separated individuals are more at risk. You may think that is quite understandable, but you also need to remember that individuals who are single are relatively less at risk compared to divorced or separated individuals. Moving on, ethnic factors. Alcohol misuse seems to be high in certain ethnic groups, the North Americans, particularly the Native Americans, Afro-Caribbeans and Irish. However, it is not clear whether this is linked to the genetics, or there are other factors, the environmental factors involved in it, such as alcohol being introduced and sold very cheaply to Native Americans. In some cases it was given freely. So one has to think about the politico-psychosocial factors as well. It is found to be low in a Jewish community, Chinese, Koreans, Japanese and other Southeast Asians. So in these communities, particularly the Southeast Asian, Chinese and Japanese, it may be related to their inheritance of inactive isoenzyme acetaldehyde dehydrogenase, but in Jewish communities it may be related to their religious influence and the community coherence. Some more detail about the actual consumption of alcohol in liters. That in individuals aged more than 15 years, the pure alcohol, the amount of pure alcohol consumed per person per year worldwide is 6.2 liters, Sri Lanka 3.7, Southeast Asia is 3.5. So you can see Sri Lanka is higher than the Southeast Asian region. And if you go into the detail, the above data is for the whole population, calculated with the whole population. But if you go into the details, that male drinkers aged more than 15 years drank 15.2 liters of pure alcohol in 97, and it has shot up to 26 liters in 2010, which is obviously very worrying. And in Jaffna Peninsula, there has been an exponential increase in the consumption of alcohol over the recent time, which is of concern for everyone. So just some data. Beer consumption in 2002, it was 555,304 liters, and it has gone up to now 40 million. So which is beyond imagination, I would say. Similarly, Arak consumption from around 300,000 liters, it has gone up to 2 million. The data was provided by the Traders as Jaffna Traders Association and published at the Mirror newspaper. And Sri Lanka has the second highest rate of cirrhosis in the world, 55 per 10,000 population, and cirrhosis seems to be the sixth leading cause of death in Sri Lanka. So this is the data provided by Dr. Anula Vijayasundara. Just to put the above data in perspective and compare with the data in UK, but as you can see, in UK 93% of men and 87% of women drink alcohol, and more than 25% of emergency hospital admissions in UK is attributable to excessive alcohol consumption. And alcohol accounts for more than 10% of all psychiatric admissions. And alcohol use and the problems caused by alcohol has been a huge concern for the UK government, and they have invested heavily on alcohol misuse services, and one of the specialized branch in psychiatry is substance and alcohol and substance misuse, and a lot of money being invested in order to curb and control this issue. Moving into etiology of alcohol misuse, there seems to be multiple factors responsible for the development of alcohol misuse and dependence. Like any other medical condition, there seems to be an interplay between genetic and environmental factors, and clearly the genetic factors are responsible for 60% of risk of alcoholism, while environmental factors are responsible for 40%. Let us first look at the environmental factors. There are a number of theories about the psychological and socio-cultural factors and how they influence the development of alcohol use and later dependence. One of the commonest factor often cited was stress. There have been some studies on how stress play a part in developing alcohol dependence. What they have found that there aren't any clear evidence that stress alone play a part in the development of alcohol dependence. However, stress does influence the use of alcohol, often in moderation. And the researchers argue that when one consumes alcohol in excess, that causes muscle tension, increased heart rate, and the rest of it, which is not relaxing, rather than it increases the tension. And also, on the following day after a night of drinking, the perceived stress level at workplace for that individual is much higher. So that is again goes against this argument that stress play a part. So the argument is it must be a combination of a number of factors rather than stress alone. And one of the other theory is the positive expectation of the impact of alcohol on social interaction and sexual performance, particularly in a younger individual. They believe that they can socialize better, develop more relationship or friendship, and the sexual performance also can be enhanced by alcohol. So this is a misperception, and as the reverse is true, often people get into arguments and fights, and sexual performance also can become difficult under the influence of alcohol. And there's the other misperception is among younger individuals is the amount of alcohol his colleague or his peer drinks. So often they they think, or they have this misperception: his peer drinks a lot more than he does, uh, and this can lead to him trying to drink more, or sort of show off that he is more capable of drinking more. And this seems to be one of the important factor, or one of the important theories explaining how younger individuals get into alcohol and later develop addiction. Other socio-cultural factors: the low-income families, a lower educational background, lack of strong religious belief, a lower socio-economic neighborhood, all seems to play a part in increased level of heavy drinking. It's a statistics. However, one has to be very sensitive, um, and avoid the risk of stereotyping individuals from this background. So it can be, um, you can easily offend um, somebody if you ask about um, alcohol misuse history without being sensitive. The psychodynamic theory of alcohol use or substance use uh, argue that some people may use alcohol to help them deal with self-punitive, harsh superego, and to decrease the unconscious stress level. Now, this is a Freudian theory. The Freud's structural model of the psyche um, describe psyche as three distinct entities: id, ego, and superego. The id is mainly the set of instincts we have, and the superego is the critical and moralizing part in our mind, and the ego is the realistic part that mediates between the id and ego, and try to keep us in a balance. The superego is formed by internalizing the rules mainly taught by parents, cultural values, and so on. So if you had a harsh upbringing, or sort of parenting, then uh, that can potentially or possibly lead to alcohol misuse. So that's what it argues. The other theory is people those who were fixated at the oral stage of their psychosexual development can use alcohol to because of the frustration uh, during the development of that stage. So again, this is a Freudian theory that he argues there are 5 stages of psychosexual development, and the initial stage, the first stage, is oral stage, which spans from birth to the 21 months. That's mainly the period when the baby is breastfed, and the early attachment and so on. So if that part of the or that stage of the development was disturbed in some way, the risk of alcohol misuse can increase. As I mentioned earlier, genetic factors play a major role in the development of alcohol misuse and dependence. There is a fourfold increased risk of severe alcohol problems in close relatives of alcoholics, and this seems to increase with the number of alcohol relatives you have, and the severity of their illness, and the closeness of their genetic relationship. And the studies on twins found that the identical twin of a alcoholic person is at higher risk than the fraternal twin. And again, adopted away children of alcoholics have a fourfold increased risk of alcoholism, even when they were raised by non-alcoholic carers. So this clearly indicates how strongly the genes play a part in the development of alcohol dependence or misuse. Further evidence on the involvement of genes in the development of alcohol misuse and dependence is the inheritance of relatively inactive isoenzyme acetaldehyde dehydrogenase in certain ethnic groups such as Chinese, Japanese, Koreans, and other Southeast Asians. And this can lead to them unable to metabolize the alcohol effectively, hence the accumulation of acetaldehyde that lead to the development of disulfiram reaction, which is a very unpleasant reaction. They get flushing, headache, nausea, vomiting, and the symptoms can be quite severe. So that act as an inhibitor from developing alcohol dependence. Let's move on to the clinical features and how to diagnose alcohol misuse or alcohol dependence. According to ICD-10 diagnostic criteria, there are certain symptoms and signs we got to look into. The first one is the individual should express a strong desire or sense of compulsion to take the substance. So in this case it's alcohol. And the second one is difficulties in controlling the substance taking behavior in terms of onset, termination, and levels of use. The third one, a physiological withdrawal state is experienced when the substance use has ceased or being reduced, and the use of substance with the intention of relieving or avoiding withdrawal symptom. The fourth feature is the evidence of tolerance, such as that the increased doses of alcohol is required in order to achieve the same effect originally produced by lower amount. The fifth one, progressive neglect of alternative pleasures or interest because of alcohol use, and increased amount of time is necessary to obtain or take the substance or to recover from its effect. The sixth one, persisting with alcohol use despite clear evidence of overtly harmful consequences. ICD-10 suggests that if a person has 3 or more of the features mentioned above present at the same time over the period of last year, suggests that he has developed alcohol dependence. If one suspect alcohol problems in a patient, we got to screen them. One of the useful questionnaire or useful set of questions, bedside questioning, is called CAGE questionnaire. The CAGE is an acronym. So C stands for have you ever felt you should cut back on your drinking? A is for has anyone ever annoyed you by criticizing your drinking? G is for have you ever felt guilty about drinking? And E is for have you ever had to drink early in the morning as an eye-opener? So if the patient answered 2 positive responses, that suggests that he or she is at risk of drinking. And then we got to ask further questions into the amount of drinking. So that is called as CAGE plus 2. So what is the most alcohol you have drunk in a single day, and what is the most alcohol have you drunk in a single week? As doctors, we got to suspect underlying alcohol abuse in following cases. If you come across a patient with the hepatitis, cryptogenic cirrhosis, seizures, gastritis, anemia, unexplained raised MCV, deranged LFT, cardiomyopathy, always suspect underlying alcohol use. The other situations like accidents, head injury, hypertension, not responding to adequate medication. And when you work in psychiatry, if you worry about treatment resistant in any psychiatric condition, and impotence in men, suspect underlying alcohol misuse, and ask direct questions, because often people don't volunteer this information, and often they downplay their alcohol use. Some objective measures or tests to test people misuse alcohol. One of them is breath testing. That it is measured by using an alcometer. The individual has to blow into this meter, which then measure the amount of alcohol in the breath. And if the breath level is more than 0.35 micrograms, uh, that means the blood level, the equivalent blood level is 0.8, that is 80 milligrams of alcohol in 100 ml of blood, which is considered as the upper limit for legal drink driving limit in Sri Lanka and UK. But one has to one need to notice that it is lower in many other countries, Australia, New Zealand, France, and it is a zero in many countries, many European and Middle Eastern countries. So it is not considered as safe, but that is how it is in certain countries. You can do some blood test as well. MCV, you probably know that mean corpuscular volume tend to increase. Gamma GT tend to increase in alcohol misuse. There's another test called CDT, or carbohydrate deficient transferrin, which is not routinely done, but it has a higher sensitivity and specificity than other tests. Treatment of alcohol misuse can be broadly divided into three: psychological interventions, which include health education, addressing ambivalence about alcohol misuse problem through motivational interviewing, which I'm going to explain later. Help them move through the stages of change. I will explain that later as well. Then the medical management of withdrawal syndrome, commonly known as the alcohol detox, and I will touch upon that. And then the important part, relapse prevention, using psychological and medication together. Health education. First of all, advice about safe drinking limits. You might have noticed that I put the word safe under inverted commas, because no amount of alcohol is really safe. But what the studies have shown, for men, if they drink less than 21 units per week, and women 14 units less than 14 units per week, the chances for them to develop a health related problem or alcohol dependence are less. So that's what it say. But the no amount is safe in certain situations, like when if you are driving, operating machinery, or if you have chronic medical condition or pregnant. Moving on to psychological intervention. People who are at the early stages of alcohol misuse or dependence, the following psychological intervention seems to be effective. So one is the brief intervention for harmful drinking at early stages, mainly done by the family practitioners or the MOs in OPD, just to present them the blood investigations showing the altered LFT and the risk associated with it, and how this can lead to further problems and so on. Giving some medical advice in a sensible way, working collaboratively, not to criticize, but more in a supportive manner, offer help. That seems to go a long way in people who are at the early stages of drinking problem. But and if the person has already started misusing heavily, or just started just recently, then certain techniques can be given for them to cut down on their drinking. So such as set a weekly limit of the alcohol limit. Now using the so-called safe alcohol limit as a goal, and then advise them not to drink alone, not to drink with individuals who drink heavily. You pace drinking, matching the consumption of a lighter drinker rather than the heavy drinker. Alternate with soft drinks. When you are in a party situation, or when you are at green grass or somewhere, when you with your friends, try to alternate soft drinks with alcohol drinks, and drink with meal. That also will help you to cut down on the amount you drink. And then if you have difficulty saying no if you're offered a drink by your friend, then that's something you need to rehearse early. So when I say you, but it's not, I don't mean to say medical students, but when you come across patients, you can advise them like that. So plan alternative enjoyable non-drinking activities to replace drinking periods. So encourage them. Things like participating in some kind of sports activities or other activities. But you got to ask them what they enjoy um, other than drinking, and try to strengthen that. Motivational interviewing. Motivational interviewing is a form of collaborative conversation, a counseling style for strengthening a person's own motivation and commitment to change. It is a person-centered counseling style for addressing the common problems of ambivalence about change by paying particular attention to the language of change. And it is designed to strengthen the individual's motivation, strengthen the positives that the individual already has, and help them to move towards a goal that is, in this case, it's change um, about their alcohol misuse. The therapist does not take a directive or prescriptive role, but expresses interest and concerns for the patient's problem, and explore the consequences of that behavior. Often they use open-ended question and reflect what the patient reflect the responses given by the patient, and summarize what the patient has said, and help them to identify the discrepancy, and aids the assessment of pros and cons of current behavior. So in this case, about the drinking behavior. So encourage them to talk about what is good about your drinking, or what is not so good about drinking, and list them both in a continuation sheet or clocking sheet, and then show them. And often you will find that there is a significant discrepancy of what they are saying, and emphasizes patients' own perception of degree of risk, rather than telling them about risks which they may not believe. They Now, for example, about the liver function test, or any other deranged blood test, emphasize sometimes they may not they may think that you are trying to scare them by giving a lot of information. So it's always good to ask them what they understand about that results, and what do they think about that results, and then build from there. Encourage personal responsibility and patient choice of treatment option. So it's the key of the essential part of this counseling is always patient-centered, and strengthen their strengths, as it were. Now, it may not be, it's easier for you to understand this if you watch a video clip. So I've just put a link here, the video I found in YouTube. I hope that is useful for you. So this is the trans-theoretical model of behavioral change, which explains the stages of change. This model helps us to assess and understanding the individual, and understand at what stage he is in with regards to making changes about his drinking or any other behavior for that matter. So there are a number of different stages, as you can see. So it starts from the pre-contemplation stage. So at this stage, usually people are not intending to take action in the foreseeable future, and often they can be unaware about their problem. They often say alcohol is not a problem for me. It's everyone drinks, and why should I bother, and so on. even when the family and others see that as a clearly see that as a problem. So with these individuals, we got to first of all help them to um, understand that it is a problem, and help them to develop that awareness of that problem. So we may need to advise them on safe drinking limits, the and how much they are drinking and what are the consequences. Maybe we can show them the blood results, and to prove objectively that, see, even though you don't claim this as a problem, but your liver is struggling, your liver is strained, and your blood cells are becoming larger and so on. So that kind of counseling um, would be useful. The next stage is contemplation stage. So at this stage, individual started to recognize alcohol use as a problem. So it's effectively it's getting ready. So individual, you may come across patients in any stages of change. So most often you come across people with either pre-contemplation and contemplation stage. So individuals at contemplation stage, we got to again motivate them, to help them to move to the next stage. Now that is the preparation, and preparation to make changes or accept intervention, psychological or medical intervention. And the next stage is the action. So here, when we say action, is mainly either psychological therapy, get into groups like AA, or if they struggle with significant alcohol withdrawal syndrome, then we need to give that alcohol detox. So that can be considered as the action in this case. And once they have completed that, then the hardest part starts. That is the maintenance stage. So which is the most difficult stage for people with alcohol or substance addiction. So they need a lot of support, encouragement, group therapy like AA, in order to maintain at that level. And problem solving, help them to develop problem solving skills, seems to be very effective as well. And if they manage to do that, if they manage to remain abstinent for a long time, then that is the end of this cycle they go through. But unfortunately, quite a number of them relapse into drinking or substance misuse. Um, so therefore, we need to help them continuously. At this stage, if they relapse, avoid being critical. That's important. And even at that stage, uh, do, do the principles of motivational interviewing, and again strengthen their own strengths, strengthen their positive, whatever positive they have, try to strengthen and motivate. So as medical professionals, we can often get into this prescriptive and advising role, or often sort of we can be judgmental or a bit critical. Usually we do that. So it's important that we don't do that in people with alcohol addiction or substances, rather than help them to strengthen and help them to reflect, and so on. So you can see that after the relapse, this person doesn't need to go through all those stages. No, he can straight away go through preparation stage, or coming and do action stage, and do that. So this is a model which will help us to understand the patient and help us to plan what kind of treatment would be useful for the individual. Let us moving on to alcohol withdrawal syndrome and medical management. So alcohol withdrawal syndrome, as you already know, it occurs around 4 to 12 hours after the last alcoholic drink, depending on how severe the alcohol drinking habit were. The features are core tremors, sweating, insomnia, tachycardia, nausea, vomiting, psychomotor agitation, anxiety, craving, occasionally visual, tactile, auditory hallucinations. The visual the hallucinations are often they report the classic hallucinations are they see insects crawling on the wall, or this small snakes crawling on the wall. The tactile ones are they feel as if insects crawling on their skin, under their skin. Auditory hallucinations, they hear voices and illusions and images they see. Often the withdrawal symptoms peak around 48 hours and can last up to 2 to 5 days. 5 to 15% cases develop a grand mal seizure, occurring 6 to 48 hours. So it's important that when you prescribe medications, make sure that you prescribe um, benzodiazepine, parental diazepam as PRN, in case if they develop seizures. We have to be cautious when treating people with severe alcohol problem, as they can develop delirium tremens, which is an acute confusional state secondary to alcohol withdrawal, and which is a medical emergency requiring inpatient medical care, and because the mortality is very high, 5 to 10%. Now, there are certain signs and symptoms: the clouding of consciousness, disorientation, amnesia for recent events, marked psychomotor agitation, hallucinations, delusions, and autonomic dysfunction. So these are the main symptoms. I'm not going to spend more time on this, as you are taught about this in medicine as well. Medical management of alcohol withdrawal is often known as alcohol detox. So I'm not going to go into very every detail into this, because you'll receive lectures on this when you do your general medicine modules. So one of the point I want to highlight is the alcohol detox without a good pre and post psychological support, without preparing the individual, and if the individual is not motivated, then alcohol detox is not going to work. So often they start drinking the moment they get discharged from the hospital. So but we all know that it happens all the time in medical wards. You know, but that's they admitted for some other reason and receive detox. But if they are purely get admitted for alcohol detox, then one has to look into this, whether the person has had proper preparation for this. Now, medication wise, we can give benzodiazepine. The commonly used benzodiazepine is chlordiazepine oxide, reducing regimes, but we can use diazepam as well, and in people with severe liver failure, short-acting benzodiazepine like lorazepam is preferred. So basically, you cut down the dose gradually over a period of 5 to 7 days. There are various regimes available, so please look at the textbooks, medical textbooks for this. The nutritional supplementation is very important, that we prescribe thiamine and vitamin B complex. Fabrinex, which is the IM preparation of vitamin B complex, um, can be given, and some centers advise to give Fabrinex routinely for the first 3 days. And it's as you might know, that the thiamine deficiencies in alcohol patients can lead to Wernicke's encephalopathy and Korsakoff syndrome, so which is a serious irreversible syndrome. Now we got to observe for complications for withdrawal such as seizures. Outpatient detox, that is in many centers in UK they do alcohol detox as an outpatient, as at home with good support from family and the community nurses and family practitioners. Maintenance and relapse prevention, which is the hardest part for any person with alcohol dependence or misuse. The psychological methods include individual counseling, help them to learn certain social skills like how to say no and how to be more assertive um, in social situations, problem solving skill, relaxation training like yoga or similar kind of relaxation methods, anger management therapy, cognitive restructuring. uh, Basically, that is about how to change the way you think about things. Then the group therapy, variety of group methods seems to be very effective. The best known is Alcoholic Anonymous. Alcoholic Anonymous, commonly known as the AA, is the best known self-help organizations for problem drinkers, founded in 1935 in the USA by two problem drinkers named Bill Wilson and Dr. Bob Smith. And it has 788,000 groups worldwide now, and many in Sri Lanka, mainly around Colombo. The AA views alcoholism as a lifelong incurable disease whose symptoms can be arrested by lifelong abstinence, which is many medical professionals and addiction specialists would agree with. The 10 to 20 people in each group usually, and they take turns to become the chairman of or the chairperson of the group, introduce themselves as I'm so and so and I'm an alcoholic. So effectively they admit that they have a problem, and then they read the AA preamble, commonly known as the 12 steps. So it's sometimes this is called as 12 steps program. It is essentially like a prayer, admitting to the God that one has alcohol problem and powerless, and sought the help from God. So there are 12 verses stating these. It also includes making pledges about remain abstinence. Then after that others share their stories and recovery experience, and leading to general discussion. The idea is you learn from each other. They learn from another person who has been through the same difficulties with alcohol, and that's often very powerful and useful, and that idea is used in other group therapy, the group therapies for other psychiatric conditions as well. And then the meeting ends with a prayer and informal discussion between members and sponsors, developing a network and help each other emotional and practical support and so on. The AA meetings are known to be very effective in preventing relapse, maintaining abstinence among alcohol misuse and drug misuse as well. Pharmacological support for relapse prevention. There are certain medications. The anti-craving drugs commonly used is called acamprosate. It acts through enhancing the GABA transmission in the brain, thereby reduce the craving for drinking. It is one has to remember it's not a wonder drug. It does help to some extent, but people relapse in spite of this medication. Naltrexone antagonizes the effects of endogenous endorphin, released by alcohol consumption. So it is commonly used in people who have been addicted to opioid, and help them to prevent relapse. But its effects, its usefulness in alcohol misuse also been recognized, and it is a licensed medication for this purpose as well. The other one is a disulfiram, and this is known as an aversive drug. So it what it does is irreversibly block the acetaldehyde dehydrogenase that can lead to the accumulation of acetaldehyde. Gives very unpleasant symptoms: flushing, headache, nausea, and vomiting. And so it's important that we advise the patient about this medication beforehand, because some people can be very sensitive to this drug and react very badly even with a small amount of alcohol, or even in some cases use when they use perfumes with alcohol. It is reported that they develop severe reaction. So it's important we need to advise them about this. Managing relapses. I've already mentioned this earlier as well. Now it's a alcohol misuse is a chronic illness, so we got to face it. The patients got to face it. So many patients will relapse several times before achieving long-standing change. So we got to be patient with our patients, encourage them and support them throughout, and better to intervene as early as possible when they relapse, rather than sort of criticizing. We helped you, we did all that, but you still relapse, and we are not going to help you anymore. That kind of approach never helps. With the families, family counseling is useful. You know, they can use certain behavioral strategies, like advise them to give reward when a drinker makes positive change, advise them to avoid confrontation or ultimatums. Ultimately, you've got to stop it, otherwise, and so on. That ultimatums never work. In fact, that can demotivate, deflate both the patient and the family. So one has to face that it is a chronic problem and people are going to relapse. Sometimes family involvement can be a negative impact also. So in that, if you see that, can advise the family to take a step back. The AA call this as a disengaging with love. So I mean, it is applicable in other psychiatric conditions as well. We call it expressed emotion, or EE. Can be counterproductive. Prognosis. The mortality among people who misuse alcohol or alcohol dependent is 3.5 times more than the general population. There are certain positive factors or good prognostic factors which are motivated to change and accept treatment, having a supportive family and or relationship, being in employment, having a treatable comorbid illness like anxiety disorder, and the involvement of AA, that is Alcoholic Anonymous, or similar psychological support groups. The negative prognostic factor are ambivalent about change, unstable accommodation or homeless, drinking embedded in their lifestyle, like having all their friends are heavy drinkers, limited pursuit outside alcohol, repeated treatment failure, and cognitive impairment. They are all negative prognostic factor. Chronic alcohol misuse, chronic heavy alcohol misuse can lead to the development of certain psychiatric conditions. Alcoholic hallucinosis is one of them, in which the patient experiences hallucinations, usually auditory hallucinations, and then the symptoms occur even long after the patient stopped drinking, and then even when they are abstinence. So that's why we consider it as a psychiatric condition. Similarly, they can develop delusions, and the popular delusional disorder associated with alcohol use is the pathological jealousy or Othello syndrome, in which the person thinks that his or her partner is unfaithful, and often it's the husband think about the wife, and it's a delusional without any evidence, and is considered as a delusional disorder. Um, Now these conditions need treatment with antipsychotic medications, and often they respond, but again can fluctuate if they relapse into alcohol again. Now, alcohol use, long-term alcohol use can lead to cognitive impairment and alcohol-related brain damage, and which can lead to even dementia. Wernicke's-Korsakoff syndrome is another complication of long-term heavy alcohol misuse, which is caused by the neuronal degeneration secondary to thiamine deficiency, most commonly seen in heavy drinkers. So that's hence we talked about the importance of prescribing thiamine, vitamin B core in every time you treat an alcoholic patient. We have to be careful about the possible psychiatric comorbidity in patients with alcohol misuse, that they may be suffering from anxiety or depressive disorder, the as an underlying condition, and often people self-medicate with alcohol to feel better from this conditions, but unfortunately it makes the condition worse. It's very difficult to diagnose anxiety and depression while the patient is still misusing alcohol, because the symptoms of withdrawal effect of alcohol overlaps a lot with the above conditions. So we got to offer them a detox and reassess them after a period of 4 weeks of abstinence. And if the symptoms of anxiety and depression persist, then treat them with antidepressant. The suicide rate is very high in dependent drinkers, 10 to 15%. Schizophrenia, patient with schizophrenia also heavily misuses alcohol. Often people argue that as a way of self-medicating, and there may be some genetic link. But then when they misuse alcohol, it is been recorded that they become more violent, they experience more side effects, extrapyramidal side effects, and tardive dyskinesia, and the compliance with medications become poor, and that can lead to relapses. Now, drug misuse also common among alcohol misuse. It's like one addiction lead to the other. It's commonly seen in substance misuse. Usual drug combined with alcohol is cocaine. Seems to enhance the effect of each other, and also benzodiazepines dependence also well known to be associated with alcoholism. So that's all I would like to say about alcohol misuse. Um, I haven't gone into detail in many areas, so I would encourage you to read around that. I left those areas mainly because you'll be taught in general medicine lectures as well about that. So I hope you enjoy that. But please, thank you for listening to my lectures. Um, so feel free to contact me on this email address on the screen if you want any clarification or questions. I hope this presentation was useful and helpful for your um, exams and information. So thank you again.